hope you know that I've got your back. I've got your back.
Hi, I'm Dr. Steve Spencer from EquiEnergy Youth. Recently, we ran our Coach to Cope Parent and Carer program for our local community. On the night, we had hundreds of families and carers come and learn on ways to support their young people through acute mental health and through episodes of distress. On the night, there were lots of questions. Unfortunately, we didn't get to them all, but we promised we would. So here they are. Yeah, that's a really good question. I guess I'd probably pull that question into a couple of different parts. It does say children, so immediately I'm thinking the age of the child. So obviously for a child under 12 is going to be different to that adolescent period. I think the normal is very difficult for adolescents, just purely because they're going through that developmental journey of individuation. So I don't think any teenager feels normal. So I think, one of the things to really think about is that we always want to work with our children and our adolescents really on about, tolerance and acceptance of the individual characteristics of all people when we think of others. So really what we want to do is just do that for the self and just acknowledge that we are all unique and different, and that's okay. I think that's something we do just right along that child and adolescent journey. I guess we just got to be really mindful for adolescents that, especially that middle period between 14 and 16, when it is that sense of identity is really quite dynamic at the time. So in regard to, I guess, specific diagnostic criteria or labels there, you've got a young person in this instance who's been diagnosed with ADHD, Tourette's and generalised anxiety disorder. I think it's very important for young children, but especially teenagers, that we always remember that we aren't our diagnosis. So, just like a person or a young person who's a human has a life experience, and for some of those people, they do meet the criteria for those specific diagnoses. That I think when it comes to mental health, I think we probably take them on a little bit more. So I think we just need to be mindful to remind young people that they aren't their diagnosis. We certainly wouldn't say to a young person, your asthma or your diabetes. And I think that we really just need to, think of the young person and their unique humanness first. And then, that there are some young people who do live with the challenges associated with some of those diagnoses. Yeah, so this is in reference to our TAR3 framework, where you're working with a young person during a time of distress. And what we're sort of indicating here is that we do know that each child has their own coping and resilience, sensory mindfulness or distraction techniques that they can tap into to manage their distress. I think what's really important here is, even as an adult, when I'm in distress, people telling me what to do is never going to go very well. So I think we should expect that children probably don't like the same. In regards to a young person, when young people are in distress and they've, flipped their lid or they've got outside their window of tolerance, so they're in that survival state of fight, flight, freeze and faint, they're probably going to be doing actions and behaviours that are challenging or scary or frustrating, or they might be angry, or I think probably the only way that we can help support a child who's in that space is to connect with them, and through that connection we can then guide them to their activity, whether it's colouring in or sitting on the lounge and wrapping in a blanket and watching Netflix or playing with a dog or whatever the strategy is. The only way they can get there from an episode of distress when they can't manage themselves is through your connection to guiding them there. Because if they could do it themselves, they would, and they wouldn't be in distress above what they could manage. Yeah, I guess what we're really talking about here is working with an adolescent about around the rules or the family rules or the curfew or some sort of boundary or limit. I think it's really important that young people do understand and know and have predictable and consistent limits and boundaries. We know that sometimes when young people push against that boundary, sometimes they don't really like the limit that's been put in place, and it might cause distress. And that's where being able to use that TAR3 framework to resolve an episode of distress. So, for example, if you're living your life alongside the young person and you put a limit or a boundary in place, and that's the trigger for distress, and there's lots of triggers, we can't eliminate them. We know children do need those limits and boundaries, but if it happens to be the thing that causes the distress, all we do is we shift and work through that episode and then come back to it when they're back in that calm space, and we can, re-talk to them and reflect and negotiate with them about the rules. But in the time of distress, we got to shift our focus about, okay, now I'm just going to pick up the baby. Yeah, that's a really good question, and it really does highlight probably the most important part of the TAR3 framework, that response and the immediate reaction you get from the young person. How the other person, in this case a child or adolescent, perceives your response is out of your control, because sometimes we can do it one way, but it's perceived another way. And that's okay. Sometimes it's perceived, for the way you intended it, and other times it's not. One of the things that's really important is that you understand how they have perceived your response, often by the reaction you get from them. So once you do respond to a young person, if what we are immediately looking for is, have they accepted your support? And if that's a description of how a response is perceived, and there's a couple of different ones, I would probably argue that this person's also done it other times where it's been accepted, and it's really about that acceptance and rejection. In that moment, as I throw the rope out to try and connect with my young person, have they accepted or rejected me? And that's generally going to guide me in that response. So, and that's feedback on how the child has perceived our initial response to try and help them in that time of distress. Yeah, this is a really great question, actually. When I was looking through it, I was thinking to myself, for all young people, we need to continually demonstrate to them that the adults around them are working together. Really thinking around that village approach to supporting a young person. If I think of that from the parent perspective, and you know your child the best, if you know that they are struggling at school, and then you're talking to the other part of the village where they say things are fine, both of those, struggling at school and fine are quite ambiguous. So really what I think is very important is for those two lots of adults to come together and be really specific about what the young person's struggling with. Is it, just attending, or is it a specific class, or is it the learning, or is it peer interactions? So being really specific about what they're struggling with, because as the parent or carer, you've got the most knowing about your child that you share with the school. But also when the school say, oh, they're fine here, get them to describe what they see as evidence that they're fine. But even we can ask the other question, are there times where you don't see that? And so we can even qualify and get them to start thinking about when you're, as the parent, if you're able to share what you know about the things they're struggling at school, you've now shared that with the school, so the school can be more likely to observe for those things, because they're probably holding it in their consciousness a bit. I think one of the things that we've done as individuals and as families and communities is learning to tolerate more and more stress, hectic life. I think it's very important that we, whether you're a child, adolescent, or adult, we all know we have a level of distress tolerance. I'm in my mid-40s, and there's still parts of things the world and the stress gets to me, where I, sort of shift to that space where I, might go in that fight, flight, freeze or faint. So I think we've just got to keep being real about, that life is stressful. Life has always been about survival, and really coming back to saying that it's okay. And because once we sort of acknowledge that, then we can start to think, how can we come together and help each individual or family or system, like a school or a classroom, or to manage stress and to cope. I think probably adding to that, I think it's really important that obviously as individuals and as families and wider community, we have these beliefs. I think one of the things that probably hasn't helped us a lot of some of those beliefs about you just suck it up or have a spoonful of concrete, or all of those, I think, which are really unhelpful. I think we need to acknowledge that for individuals and families and even as systems and communities, that it is very stressful, especially on the back of what we've had, a really disruptive time over the last couple of years, and some quite big things happening in communities and societies. I think we just need to acknowledge that it is stressful and it's okay, and to help improve help seeking of all Australians, but especially our children and young people, I think we've got to probably move away from some of those unhelpful beliefs and things that go against it. Yeah, I guess from that question, I'm making an assumption here that someone's saying, do we believe they have a mental health problem, or do we believe they're in distress? I think whether it's meets a diagnostic criteria or what the motivation is or any of those things, I think if any young person is expressing to us that they're struggling or not coping in any way, it's all a way of communicating. And we know that children, as they get older, they get better at this, but all young people have, really helpful ways of asking for help. But we know that at times they're still learning how to do that. And that when they're not able to do it in helpful ways, they are going to do it in ways that, where we might start to question the validity of it. But I think if we take that judgment aside and think whether the young person's asking in helpful ways or not so helpful ways, they're still asking for help. And so my thoughts is that I always believe them, and my job then is to connect with them, and then I'm just going to be curious. I'm just going to start to try and understand why they've, why they might be asking for help in helpful or unhelpful ways. I've had the privilege of working with thousands of young people who engage in self-harm behaviour. Many of them have described to me that self-harm does release that psychological distress or pain. Our brains don't do a very good job of differentiating between physical and psychological pain. If we have an accident and fall over and hurt ourselves, graze our knee or something like that, we do get a release of chemicals in our body that do help with pain relief, so natural endorphins. And so that same process does occur if a person injures themselves, not by accident, but by their own hand. So there is a level of, it does provide relief at both a psychological and a physical level, by biological level. I guess probably the most important part is there's two different things. Whenever I'm working with a young person engaged in self-harm behaviour, there's the times I'm working with them in the moment when they're actually self-harming. My first response in that situation is to assess the level of severity of harm. If it is very high and life-threatening, I'm going to do everything I need to keep that child safe. But if it's not life-threatening, what I'm going to do is try and connect with the young person and just help them through the episode of distress. I'm not necessarily going to stop them or any of that. So I'm just going to try and connect with them and help them. And through that connection, through that TR3 framework that we coach, eventually the young person will get back to that mild or calm space where they can manage and they're coping again. And then I can talk to them, an hour later, a day later, whenever, I can reflect back on the things and try to prevent it moving forward. One of the things that happens if a young person is engaging in self-harm behaviour and we can respond to them in helpful ways like that, we're not reacting to it. We're letting them know that we're there to help, and that will reduce that shame and guilt, and it can often be associated after a person has engaged in self-harm behaviour. So we're really just demonstrating that calm, connected response and getting them through that episode of distress. If I'm working with a young person who, as I'm talking to them, I realise or they share with me that they've self-harmed, prior to me being present, like maybe a day ago or an hour ago when I wasn't around, again, I just want to do that, acknowledgement and validation. You must have been having a difficult time before, I know that your other coping strategies might include, playing with kinetic sand or, going for a walk down to the nearest park. So I'm just reminding them of their helpful strategies. And then I'm just trying to seek to understand, what do they need from me now? Is there any medical attention? They're going to let me maybe assess the severity of injury. And I'm just thinking, okay, does this need a Band-Aid or some ice, or does this need medical attention? And obviously, we're always assessing for any life-threatening. In that question, there was also that statement about not really understanding, and managing an episode of distress, psychological distress through self-harm is one reason why young people engage in self-harm. I've had lots of young people share with me many other reasons why they do that, and some of those might include, in addition to managing an episode of distress, it's sometimes a way of managing at times where it prevents a person moving to suicidal behaviour. So it's almost like if I self-harm, I won't get to that next level. I've also had young people say it's around punishment of self or others. Sometimes it's that contagion effect, as in, some of my friends self-harm and that social belonging and contagion that does come with self-harm and suicide. So there are many different reasons why young people engage in self-harm behaviour. Yeah, technology is just a part of our current society. We live and work every day with technology around us. It's part of being alive in this contemporary society. There is lots of research, and to show that all the wonderful things that, or not even research, but just experience that technology can do wonderful things. Also, we know that technology does have an impact. I try not to do good or bad. I think probably from this perspective, the thing that I think most of is how difficult it must be for young people to disconnect from technology. I think there's a really great book by Richard Louv called The Nature Deficit, Last Child in the Woods. I think technology has significantly impact on our children and young people's connection to nature, which is where we learn, and historically, most of humankind has spent in nature. I think that's been probably one big thing that technology's done for our young people. We also know that the amount of information and data and sensory overload that technology has for our young people in this society. Like I mentioned, I'm in my mid-40s, and when I was younger, there was far less data and sensory overload because we did have those long pauses between, when I was younger, for example, there were only a couple of channels on the TV and you had to wait for the TV to come on. So I think that plays a big part. I've read a really great book and I recommend it to any person recently. It's Johann Hari's Stolen Focus, and it really does look at one chapter or two chapters of that book, really look at the impact of technology on things like focus, attention and concentration, which I think currently we're probably misrepresenting through ADHD, when really it's the impact of, one of the causes would be the impact of that significant technology overload for young developing brains. we are having increased presentations to emergency services and emergency departments for mental health presentations. So certainly for that. I think also, to reduce stigma, we've become more aware of it through, great awareness campaigns. So I think there's less stigma there in previous generations, so we are more aware of it. And I think one of the things that we try to do at EquiEnergy Youth is try and put that practical skill and support for that awareness, because with awareness is one thing, but we need to be aware of it, and then how to manage and support people is a different thing. And that's, so awareness is one part that's really important, but we do need to be able to support people when they do become aware that a young person might be experiencing challenges around their mental health. In a lot of the professional training we do in our Coach to Cope programs with nurses and other health professionals and educators, and we often get asked or have a bit of a debate about whether or not children's coping and resilience is decreasing. And lots of professionals I've engaged with, 10,000 over the last couple of years, lots of them have said, children don't have the same level of coping and resilience that previous generations. I don't know if that's entirely the case. That might be true, but I think that contemporary society right now and living in this area is probably more stressful than maybe. And I don't want to, certainly don't want to discredit previous generations and but certainly living in this contemporary society, is fast-paced, overscheduled, and stressful. And there's lots of pressures on young people and families and the community. And, so even if coping and resilience has stayed the same or even increased a little bit, I think the level of stress in our lives has significantly increased. This is where that TAR3 framework really goes alongside our Connect to Cope model. So the Connect to Cope model is about understanding that young people can be in that calm space and that sometimes they get to that mild level of distress, but that everything in that calm and mild space, the young person can manage themselves. But once a young person sort of shifts to more moderate distress and they're now not able to cope, essentially they've gone into fight and flight, what we need to determine is the level of distress. The three things you need to do to support a child with distress, the first one is to manage your own, which is what I think this person's indicating. And the next one is to be able to assess the level of distress. The first thing is to assess is this child outside of their ability to cope? If that's the case, they're in that help-seeking action, the fight, flight, freeze and faint, the really unhelpful ways of letting us know that they're not coping. Again, I think we're conditioned as a society to see these things as naughty or, not or attention-seeking behaviour, but essentially what a child is demonstrating there is that they're not coping in that moment. So whenever I'm assessing a child's not coping, the next thing I want to do is determine, is it life-threatening? And if it's life-threatening, even if I'm struggling, I've got to be the adult that child needs the best I can. But if it's non-life-threatening, and it's sort of essentially what I can do is determine, is it more important for me to ground myself? And I think in most instances, it probably is about in that moment of distress, when the child's outside of their window and they're not able to cope, I think we need to just step up and help them through and get them to when they can cope. If they're coping and they're below that level, we can step back and invite them to do it and attend to ourselves. But if they are in distress, we've just got to help them through the episode. It's really what we do from there to try and put our oxygen masks on. I think one of the important things is, rather than trying to put our oxygen masks on in the times of distress when our children need us most, how do we do it consistently, just little bits through the day, through the week, so that we are, as best we can in this world, at our best for when our young people need us most. And some of the work we do is help, to try and identify patterns or times and contexts where a child is likely to be distressed, because then you can, sort of manage your energy and resource at an individual level, the more we get to know young people. And I think what that question really does is needs to be pulled apart into two parts. So we're talking about a young person who is maybe not helping themselves or rejecting the help. I guess there's a difference there. There's a difference between a young person saying, I don't want to take medications each day, or I don't want to attend a psychologist or a counsellor or mental health service, and that's what we call treatment. So that's a young person sort of saying, I don't want to do that over a period of time, which is different to when a child rejects our help and support in the moment. And that TAR3 framework is about any moment when a child is not coping. So I guess if a young person's rejecting being actively involved in their treatment, for example, taking medications and going to appointments and things, certainly we just want to keep working with them to help them to identify some of the benefits that might have. But then when it comes to a young person rejecting us in the moment when we're offering support during a time of distress, again, we go back to that TAR3 framework and we just recognise in the moment the young person's telling us either we didn't quite get it right or that we did a really good job, but they're just not in the space to accept it right then. And all we do is just slow everything down and just keep trying to connect. We don't go to tell it, fix it, explain it mode and those things. All we do is just slow everything down and just keep trying to connect and help them through that episode of distress. Yeah, I love that, Normal. So young people don't learn by us telling them what to do. Young people learn by pushing against the boundaries and through experience. We grow connections in our brains and pathways through our experiences of life. So all children need boundaries, and they need to be what we call age and stage appropriate. So they need to be the right size for the age and stage of development of the child. So obviously boundaries are much smaller for younger children, and then they get more and more wider as the child gets older and more autonomous. For example, think of supervision levels. You supervise children that are very young, but your 16, 17-year-olds are going out into the world and catching buses and driving cars but they're doing things a lot without this amount of supervision for a younger child. So that's a boundary, isn't it, supervision? So I'm just using that as an example of age and stage. The other really important thing is young people learn by pushing against the boundaries, and all boundaries along with age and stage need to be firm enough to contain the young person, something to push against, but also flexible enough that they don't bump against it every single time they do it. For example, we might do some, as an adult, we might do some casual speeding and go over 60 k's an hour, but we don't get a fine every time we do it. If we're very rigid and firm in our boundaries for young people, every single time they bump up against it, they're going to get chastised or corrected for it, and that's not entirely helpful. So we need to be firm enough but flexible enough to get away with a couple, and it's really determining, in each setting. And for the adults, it's really about being consistent and predictable enough. That's very important. Children need to go across multiple adults and certain places they go, and the rules need to be as consistent and predictable as possible. That's very helpful. I suppose, really understanding what are the non-negotiable rules and boundaries. What are the ones that we're going to have some discussion with them and maybe the other adults? And what are the things that are free reign? What can they do and, inside the boundaries? And so really having an idea and, for example, to parents or carers or whoever, talking about what are our non-negotiable ones. And, the older the child, the more you're communicating those. And, I think that's really important. Yeah, so if we're not coping in the time when using the TAR3 approach to trying to support a young person in distress, if we're not coping, obviously we want to look around and see if there are any other adults who we could recruit in that moment. If there is, that's where we get into that followership and we support them and we get them to do the leadership, and we work together. If there isn't anyone around, like the child and you, we're all doing the best we can with what we've got in that moment. So, we just fail forward. I think sometimes we get lots of pressure and, there's no perfect. So I think, just cutting ourselves some slack, saying, you know what, I'm doing the best I can. I've nursed thousands of young people in acute mental health setting, and I'm pretty sure they've told, would be able to tell you I haven't always done it my best, but I've done a great job, but I've always tried my best. In regards to, withdrawing away from a young person and being triggered, look, that's attachment in action. The closer we are to people, the more it hurts. If you think of that TAR3 framework, it is far more difficult to be rejected by your own child than by someone else's. I often say to families I've worked with, it's far easier for me to nurse your child than it is for you, because when they reject me, it doesn't hurt so much. So it's understandable at times to be triggered by our young people, and vice versa, because we love each and care for each other and we're close, and that's how attachment works. I think what's really important is to maybe even sometimes seek our own help to better understand why the young person triggers us, and which we can do separate and figure those things out. That might be helpful. We'll have a bit of reflection about what it is and about the young person, what they do and say that is most triggering for us. One of the things that does happen is often young people reject us to test us. And so when a young person rejects us, it is triggering, and it does raise distress in you and potentially a young person. But if we withdraw at that moment, sometimes that's what they're testing. So sometimes if we're able just to acknowledge, okay, this is triggering for me, but how do I stay grounded? And I will often do things like just take a deep breath, and I'll do that self-talk that says, all right, Steve, everything's okay here. Let's just try and connect with this young person. Let's pick up the baby. I'm sort of trying to do something to ground myself in the moment, to try and focus on just keep connection, even if the child's trying to push me away and test me. And oftentimes what I do is just use silence. I just try and sometimes let it, as they're pushing me away and rejecting me, I'm just letting it wash over me, maybe like the waves wash over me a little bit, but the set goes and there's going to be a little period of calm where I can try and reconnect. That's a great question. I guess there's two parts that come to mind there. The first thing is that we just want to continually build that coping resilience and give them good experiences of helpful adults, which is what the TAR3 framework and the Connect to Cope model are all about. If we can help build a child's coping resilience and ability to ask for help, whether the trigger is, the perfectionistic trait or something, or any other trigger, they're going to be able to manage more of life with increased distress tolerance and a schema or a view that adults are helpful when I'm not able to cope. So it's really just reinforcing and having more and more positive experiences of that TAR3 framework. I guess the other part is in relation to the specific, trigger of perfectionism and people pleasing. I think that's just a developmental journey, and that we just show and help support young people and to let them know that we fail forward and that we learn through our mistakes, and that we use language and things that are, that we can see that those things will be frustrating. So we just validate that, that experience must be frustrating, but hey, it's okay, and just be just consistent in that message. Sending messages that, it's important to be kind to everybody, but you're not going to be able to please everybody. And, just little, just constant messages to try and negate some of the things that might be happening internally for them. I think it's really important that, and I'm speaking specifically to parents here, it's very important that as parents, especially for teenagers, we just keep that door open, that we let our young people know they can come to us with anything. When it comes to the attachment framework, we know that young people engage with different members of the family, but all different adults in different ways, and which is very important. There will be things that your teenager won't want to ever talk to you about, which is so important that we really do get that village around young people, and that we as the adults are connected around. Because, so for example, there might be things that my children, I've got 3 daughters, that will never talk to me about through their teenagehood, but hey, are there family friends or aunties or teachers? There are all these other adults that we know that they can go to with those things. And if any of those people thought it was really a safety concern, I would expect them to come and to talk to me as the parent. But if it's not, it's okay, because the only challenge is when young people don't have those adults around them. They're not going to always open up and share those things with you. All they need to do is know that you've got the door open, that they can come to you with anything, and just keep inviting them, but don't pressure them. Maybe even ask them, look, if you think that there's something going on for your teenager, just say to them, look, if you can't talk to me, I wonder who else, work with them and think who else in the village might they want to talk to. And then that way, if you do have safety concerns, you just expect that adult would let you know. But, there's, young people, there's lots of evidence, for example, that in teenagehood, having non-parental role models and mentors is really important to help young people through that journey. Just a continuum. What we're saying here is the person's level of mental health and well-being supporting the child's development? Are they going okay? Are they living their life without too much distress in their life? Or is it, as they're living their life and they're on that journey, are there things that are causing them distress which impact on their mental health and well-being? And yes, we can put them into boxes and diagnose them, but all of those things are just human experiences. So what we're really determining here is this child struggling or coping or not, and how do we help them? How do we wrap around and help them? So I think there's also something that happens in our community where, mental health diagnoses are given to a young person at times, which is more about the system than actually the criteria of the health problem. So, for example, there are young people, for example, who get certain diagnoses because funding is allocated by that, or you get a bed in hospital because of it, or that you don't actually meet the criteria medically. It's like, I love ice cream. If I have ice cream, my blood sugar level goes up, but that doesn't mean I have diabetes. So, but what we're going to do is give you diabetes, Steve, just so you can go and get the support you need. That's symptoms are human experiences, right? We just put them in boxes. So that's saying to somebody, don't feel anxious is not going to be helpful. And it's really, I think, a large part is, how do we just validate people's experiences without determining if it is mental health or if it's not, or certainly there are large parts of the system where we have to do that for those. For what the system requires. But I think if we just keep coming back to, you're a human, you're part of a family, you're part of a community, and how can we help your experiences of this life, and how do we help you feel the best you can to live your life? Then if we can understand the things that aren't so pleasant or helpful, or whatever that experience is, a feeling of anxiousness, a thought, and not so helpful thought, or a perceptual experience where you hear or see something other than people don't. It's just really about understanding the meaning of that for people, what it means for them in their life, and how can we help them to manage that. That's right, absolutely, yeah, because the best way, I always take it back to physical health as a bit of an analogy because of that. I can run around, outside and get breathless. It doesn't mean I have asthma. It's a very different thing. I like ice cream, my blood sugar level goes up. That doesn't mean I have diabetes. So, it's okay. We all as humans are going to young people are going to experience the range of emotions and experiences and the challenges, and I think we're very quick to label and diagnose things rather than just and really just thinking about what's the benefit of putting a young person into that box. And I have worked with young people before where they've it's helped them to understand themselves better by being able to go, these are other things that happen to me. But also, I've probably worked with lots of young people where that stigma and stigma from others and the self-stigma of being labelled hasn't been helpful. And for many young people I've cared for, that they actually didn't even meet the criteria. We gave them that diagnosis. I worked in an acute mental health inpatient unit. We gave them that diagnosis on their paper because they needed that to get to bed that night.
I've got your back.